via email to md.coph, Maryland.Commission on Public Health, COPH, at maryland.gov. Once again, md.coph at maryland.gov. We also ask members of the commission who are on the electronic means of connectivity to mute your microphones when not speaking, and please use the raise hand function to indicate that you wish to speak, and you will then be recognized. Individuals who serve on the commission are subject to Maryland public ethics laws. All have confirmed their agreement to this in their applications and listed any conflicts of interest. I'll remind the commission members that there are attendance requirements for individuals appointed by the governor. And in essence, we will be taking minute or attendance shortly to monitor that. In the long run, the law says that basically we as commissioners should be in at least 50% of the meetings of the board or the commission during any consecutive 12-month period. This does not apply to ex officios. I will now ask Michelle Kong, who is now assisting with me with the meeting, to conduct a roll call of the commissioners.
Thank you. When I call your name, please respond with here or present. Meenakshi Brewster. Boris Lushniak.
Here.
Oluwatosin Olateju. Present. Heather Bagnall. Camille Blake Fall. Here. Christopher Brandt. Jean Drummond. Nilesh Kalyanaraman. Ariana Kelly. Alyssa Lord.
Hi, I am an intern and I'm serving in place of Senator Ariana Kelly. She's in JPR right now, but I'm excited to take some notes.
Thank you.
Alyssa Lord is here.
Alyssa Lord is here.
Nicole Rochester.
Here.
Mara Rossman. Michelle Spencer.
Here.
Alan Twigg.
Here.
Thank you.
Do we have a quorum?
Yes, we have.
Okay, we have a quorum. Quorum defined for our commission is 50% of attendance plus one, and so therefore we do have a quorum. The agenda for today's meeting has been posted, distributed to the commissioners. Are there any comments from commissioners on today's agenda? Looking around the room, I see none. Looking on the screen, I also see no comments. If there are none, I ask for a motion to approve today's agenda.
I move to approve today's agenda.
Okay, approved by
Second.
Tosin. Second by Fran. So the agenda minutes or the agenda is accepted for today's meeting. We also have posted and distributed to the commissioners minutes from the previous meeting on February 1st, 2024. I hope people had the opportunity to review those. Are there any comments on the minutes? In the room, we see none. On the screen, I also see none. Do we have a motion to approve the minutes from the February meeting? Motion to approve?
Second.
Second. Okay, now we have the opportunity. We're trying to sort of set up a world of our meetings, as you can tell, is by starting the first half of meeting with presentations so that we as a commission learn a little bit more. As you know, in the past, we've had presentations about the Maryland Department of Health, about local health departments, other entities. Today, we're honored that we have two guests who will be doing back-to-back presentations. After that, we will have a short break, and then we'll move into some of the work group presentations where we as commissioners will be briefed on some of the progress made within our work groups. And so I'll allow Tosin to welcome our first presenter.
So today I'll be welcoming the first presenter, Craig Brown. As the president and CEO of Chesapeake Regional Information System for our patients, which is one of the scripts. Craig is the lead executive responsible for developing and executing strategic plan, as well as ensuring strong financial controls and high quality services. Craig is here winking to me to say, "Oh, you want to do
That's
the
funny.
free
That's
fire,
more than
but-"
enough.
But it's notable to just say that Craig has also led the startup and operations of 3 physician-led advanced payments Medicare shared savings program, and he has a master's of business administration from Loyola University. Welcome, Craig.
Thank you. Thank you. So I am happy to take questions as we go. If people want to shout, this can be very conversational. Hopefully it's not the first time many of you have experienced CRISP. So we can dive in. And Meany, do you want me to say next slide? Is that?
Yeah.
Okay, next one. So just a way of quick background, CRISP is the state designated health information exchange here
Let
in
me just
Maryland.
interrupt 1 second. Are individuals on the web seeing the slides advancing?
No.
No.
Advancing, no.
Yes.
Trouble when
Okay.
it's full screen, so you might just have to hold the window. Yeah, like that.
Yep, that-
Okay, can we see this crisp slide now?
Yes.
Okay, thank you.
Thank you.
Okay, perfect.
Can you all please put it in presenter view if possible?
Yeah, because it doesn't advance when we do that.
Yeah, unfortunately, our technical difficulties don't allow us to, because then we can't advance them for some reason, so.
Okay, no worries.
They can do that. I enlarged it a little bit for us, so they might.
I'm told that if you want, you can potentially enlarge your screen, but hopefully this will be, and we'll also have obviously paper or this on the website as well, so.
Okay, so we're state designated. I can get into what that means, but CRISP is an independent nonprofit, essentially set up to be the health information exchange. We were designated through a competitive process back in 2009. And really the point of CRISP, as you can see in the vision statement, is advancing health and wellness through cooperation and collaboration. So really what we do is use best of breed systems and bring partners to the table to drive positive outcomes across the entire health system. Let's go to the next slide. A relatively new thing happened a couple of years ago, which is that the Health Information Exchange, which has really always been thought about kind of transactional sharing data from one hospital to one primary care group, or from essentially providers to payers or payers to providers, deliberately embarked on a mission to become a health data utility. It was an acknowledgement of the fact that we're doing a lot of work with population health, with the Maryland model, and with public health. And so we want to expand kind of the formal participation, the formal purview, to consider kind of all actors within the healthcare ecosystem, not just the traditional healthcare providers. Can you go to the next one, please?
Next slide.
She's working on it. That's okay. That advanced it. That worked. Let's go one more. Just from a timeline perspective, and this might help set the stage for the kind of the culture at CRISP and why we are eager to be such advocates and partners to this conversation. So CRISP was founded in 2006. This is a relatively common experience across health information exchanges nationally. You had different stakeholders come together. Here in Maryland, it was at the time, the 3 largest health systems: MedStar, University of Maryland, and Johns Hopkins, but also John Erickson from Erickson Retirement Communities. And they were solving a very basic problem, which was that a resident from Charlestown in Catonsville was going down the street to St. Agnes Hospital. Both places had electronic health records, except when the resident came back to their medical center at Charlestown, in the words of John Erickson, we had no idea what those people did to him. And so he was really looking for what's a better way to get more up-to-date information from point A to point B. Something that was unique here in Maryland was that we kind of, through John's sheer force of will, but then those 3 institutions got everybody at the table. And that's why stakeholders, collaboration, cooperation become such key themes for us. You see in many states that you'll have kind of a provider group or provider-led HIE that doesn't work well with payers, or a payer-led HIE that doesn't work at all with Medicaid, or a Medicaid-led HIE that doesn't incorporate public health. And as you can imagine, that just doesn't work very well. That's been a key part of what we focus on. Kind of throughout the next 15 years or so, we've essentially pushed to evolve. We're very quick to say we don't exist for the sake of existing. And so we try to solve problems. And as those problems become commodities or solved through other industry partnerships or through other ways, we're happy to go on to the next problem. So first, it was just kind of point-to-point connectivity on admissions, discharges, and transfers. Then it became pushing that information out. So a primary care group could proactively follow up with a patient for a transition. Then it became working with the HSCRC on population health and the Maryland model. And then more recently, of course, prescription drug monitoring program, public health information. And I guess we're looking to you all to tell us what to do next. The next slide is a very brief technical diagram. Or maybe a very high-level technical diagram. I can get into more detail kind of if and as folks are interested. But the way I think about this is that you have a lot of source systems, a lot of data submitters on the left side. This includes all the hospitals in the state, vast majority of primary care practices, majority of the skilled nursing facilities, actually a fair number of behavioral health and SUD providers, payers, MCOs, Maryland Department of Health. They're all submitting data in various formats. And then we're taking that data, we're normalizing it. We are linking it across a master person index. So all the data comes in at a person level. It gets linked across different systems. It gets put into a data lake. And then we provide the data through a variety of different outputs. The kind of core infrastructure is HITRUST certified, ENAC certified. We're audited by the Healthcare Commission. Happy to talk more about privacy and security if you all would like. And then also you'll notice there's a little box that says consent utility. Maryland is an opt-out state, so patients are allowed to opt out of their data flowing from CRISP, except where it's required by law for something like the prescription drug monitoring program. And then those outputs on the right side, I'll get into what that actually means for individual users, but essentially the summary of this slide is we get a lot of data in, we link it, and then we push a lot of data out in a variety of ways. Next slide is just talking about data quality. We probably can and should get into more detail about the specific pieces of data, perhaps as a discussion point either today or in one of the work groups. Because obviously the data we have, the kind of breadth, the quality, and the data use rights around it are what would prevent us or enable us to do all the different things you all would like us to do. But just as a brief summary, we have really robust quality and monitoring systems, and we have a lot of coverage on person level data. So if we're looking at things like updating phone numbers for contact tracing, lots of phone numbers, lots of capability there. And we've kind of gotten deeper into these different data elements to look at, immunizations and chronic conditions and all sorts of kind of other pieces of data that can be linked and then shared for different use cases.
Do you have any experience with like sort of stratifying populations so that you could target interventions on a population health level, at least like related to maybe COVID or some examples like that, where it's sort of like relevant to the local health department?
Yes, so I'm going to try and answer your question, but keep asking it. So one example of an intervention, which was not stratifying a population, but is driving a health department intervention. So we work with Dr. Cliff Mitchell on an asthma kids program. And the kind of problem in this case was there was a Medicaid sponsored program to support children with asthma so they wouldn't go to the emergency department. We know children, we know if they present with asthma, and we know in real time. And so when a child presented the ED with asthma, we would send a notification to the health department to do a real-time intervention. That you could see kind of in reverse, you could look at population level data, the prevalence of children with asthma by area, and then decide if you wanted to do an intervention like that. It's probably really important from a data use standpoint, just because we have the person level data, Doesn't mean we can give it out to I can't give kind of all children to all people, right? But I can tell you the population level where there might be opportunities.
So Craig,
And if you would repeat the questions.
Oh yeah, I'm sorry.
No,
Yeah.
because we're just sort of that. Fran, go on.
could you explain what's on the slide on the left? Difference in percentages of completeness of data in those categories. I don't quite get what that's saying.
So that is telling us that, so I'm sorry, the question from Fran was, what are those different percentages indicating in this slide? Essentially saying that of the 16.6 million admission, discharge, transfer pieces of data that came in January, we had race on 95% of them. And we had ethnicity on 93% of them, gender on 100%. So it's essentially supposed to be an indicator of if you wanted to do something like understand health disparities, we would be a good spot.
Snapshot for that one. Oh, okay.
Yep.
Craig, is the reason why diagnosis is not a percentage to have one missing data, is that because of the different structure coding that's being used across the different systems, so there are interoperability issues, or is it just that data is missing?
So it's probably two reasons. So the question was, why would something like diagnoses be lower in terms of kind of completeness? So one reason would be, not all sources could give a perfect ADT to us, so it might just be missing. We have other data connections, so diagnoses might be better completed through clinical documents. So even if it's not available through ADTs, it might be available through other means. So it's a good example where we want to get into more detail if there was a specific request. Let's go to the next slide, please. So this is, maybe this is a slide worth kind of pausing on a little bit, because I think it summarizes pretty nicely the core services we provide. So first is information at the point of care. And very traditionally, this would be if I'm an ED clinician and a patient presents, I can pull up information about that person regardless of where they went prior. And that's essentially what HIEs were set up for initially. We provide that data through a secure portal or through essentially an EHR embedded application or through individual pieces of data. It's kind of however the clinician would like to see it or however their health institution allows them to see it. And that's kind of accessing data in that way is done 250,000 times per week. We push notifications. So the example here would be I'm a primary care group and I want to know when my patients are discharged from the hospital to do follow-up. One of the really important things about that service and how it's evolved over time is that it's much more of a rules engine than an encounter notification service. And so if you think about all those data elements we talked about, really what we're saying is, if you give me a person and something you want to know about in real time, I can tell you when it happens. So if you have a diabetes prevention program and someone has a lab result that has an A1C above 7, I can notify you of that person who didn't have a diagnosis of diabetes and does have maybe an indicator that they should be in a prevention program. Or if you have a child who goes to the ED and has asthma, then I can notify the person of that. So it's a really nice way to kind of drive specific interventions for specific populations. Next one, we do a lot of population health reports. These were initially created for the Rate Setting Commission, who we work really closely with. Maybe it's not to bury the lead, but this is a good time to note. So in addition to all of the kind of real-time clinical data from most of the sources across the state, we do have all the hospital case mix data. Those are the all-payer hospital claims. We also have Medicare claims, and then we have Medicaid claims. So we have really broad claims coverage. It's probably also worth noting each of those types of data is covered by its own data use agreement, which restricts it to different purposes that we can get into.
But what about pharmacy, also pharmacy, someone on pharmacy, medication, then you got prescriptions, not pills, right?
We have CDS prescriptions. We do not have good pharmacy data. It actually was a law passed a couple of years ago to to mandate pharmacies connect, and they've been very slow to do so.
There's
Yeah.
another function, I'm not sure if it's in any of those five categories, but during the pandemic, CRISP was incredibly useful with real-time information about acute care resource use, utilization in real time. So how many COVID patients were on ventilators in real time or in nursing, at all levels of care. And so that kind of intel we didn't really have. And so I don't know that, I just feel like that might not be just a crisis capability.
Yeah. So Fran's example, and there's actually a lot to unpack there that I'm not going to do a ton of today, but
I'll have PTSD.
that Chris was supporting resource utilization. So I would say one really nice function of CRISP as kind of your nonprofit designated tool is, if there's data that needs to go from one place to another or get linked across places, we're a neutral convener to do so. But also we don't have to do so. So in the case of like a bed registry, kind of post-COVID, there are other plans with MHA and MDH to kind of build a more robust system. And if we can be helpful, we're happy to be, but my guess is that's not a CRISP system long-term.
Right. But I think that speaks to the governance and kind of the culture and history of CRISP as it has evolved, is that when there's that kind of urgent need, CRISP steps up. So I'm going to come back to one of the things, the many things that are unique about Maryland, but this is one of them. Yeah. Other states would love to have this HIE.
Yeah. Well, and there's some cool, so COVID, not to get too into the weeds, one of the things we did during COVID, in part thanks to Fran, was driving public school data into the broader healthcare system. And so we fought through the FERPA battles and the HIPAA battles. And because schools are users of ImmuNet in law, we were able to act as the intermediary between the Department of Health and school jurisdictions to provide COVID information to schools. Since then, we've actually expanded that information to all immunizations. So now if you're a school nurse, instead of querying one kid at a time, you can get essentially a report that says, these are the 15% of the kids, we just don't know if they have a complete vaccination. And so,
Chris to push attendance data from schools into primary care EHRs and DC, right?
Yep.
Does that, whether that is scalable, whether that could help in Maryland or whether it's helping to utilize school attendance?
yeah, so Chris's question is about school-based attendance data in DC, because Chris has been with CRISP since the beginning and has a lot of its history. So CRISP, let me just say, CRISP Shared Services operates HIEs in 5 states in addition to Maryland. So we have some other history that we can bring to the table. In DC, we worked with DHCF, their Medicaid agency, and their public schools to take absenteeism data from the DC public schools at a child level, send it to Medicaid if they're a Medicaid beneficiary, so that Medicaid could follow up to see if absenteeism was driven by health issues. We're still doing that, and there's no technical limitation to any of this stuff. It's a question of kind of the will and cycle. In DC, we're also supporting the DC lead registry. So same thing, if there's, and I'm not going to try and pretend I know the clinical diagnoses, but if there is a child exposed to lead, I guess indicative of a clinical visit, they go back to the lead registry and go for follow-up and other supports. But from a technical standpoint, it's, kind of data in, matching the person, creating a rule, and data back out.
The component of CRISP here is probabilistically match identities across different data systems. So it's this infrastructure that's built, one, to really efficiently integrate systems and then apply this matching capability.
Yep. Yeah, so Chris was talking about the kind of probabilistic matching capability. The thing that I think helps make this very powerful is this, like, we have broad coverage, which is not true in most states, and that's because of all of you. But then also we have really robust governance. And so if MDH wants population level data, we can create population level data derived from individual data. What that means is you're using the same information to drive interventions. So instead of kind of using Burfus on one hand and kind of getting 18-month-old data to be directional, it's all the same information. So you can do some really precise tracking on outcomes, on kind of efficacy. Let's keep going. I think the next kind of handful of slides are just kind of getting into the detail. So showing what the data looks like at the point of care. Let's do one more, please. This is so this is a picture of the prescription drug monitoring program information, but it's a really maybe important kind of highlight to Chris's point about matching data from all these different systems. So we know we operate the PDMP for the state, so we know all the CDS prescriptions. We also know all the dispensers, prescribers. We also know, because we have the real-time clinical feeds, when a person has presented in an ED or has had EMS interactions with a non-fatal overdose event. And so we can do things like create a rule that says, if you're a clinician and you go to prescribe a CDS substance to someone who has a history of non-fatal overdose, we pop up an alert that says, are you sure you want to continue? And completely different systems, combining them and creating an alert. And again, you can kind of think through the puzzle to put that type of thing together in multiple different ways.
Well, it also relates to public health on the ground, the harm reduction programs who may want to do some follow-on care for the individual and offer naloxone or other kinds of interventions. So
Yep.
both the provider side and
Yep. And we push the non-fatal overdose events to the LHD jurisdiction where the person lives, regardless of where the event happened. Yeah, it's me. I think we can kind of click through the next couple. Let's just talk about the reporting services. Let's do the next slide, please. We do have a public health dashboard. We worked with a handful of folks, both at a couple LHDs and MDH, to take the hospital case mix data and to put it into the reporting suite so we can do things. And these are way too small to see. But you can look at kind of county, census tract. You can filter by race, ethnicity, age, chronic conditions to get a sense of certain prevalencies. There are some really important nuances. So, for example, of course, we do cell size suppression, because if you start to filter too tight, you can almost identify people. Also, the information here is derived from case mix data, so it's only people who've touched the hospital. Maybe my note here, and this is probably worth a follow-up item, is that it's really great data. It's probably better than other data. It's certainly more timely than other data, but we just need to be aware of where these gaps exist so that we don't accidentally kind of go down a path just without knowing it.
I have a question.
Yeah.
What systems do you have in place to prevent redundancies, especially as you have your data coming from different streams in the state?
So the question was about redundancies. How do we block it? So kind of all the systems do that. It's like the trick to all this is kind of handling the influx of inbound data, linking it to the person level, and then dealing with duplicates or individuals that should be combined to deduplicate records.
Okay.
Like every time there's a hospital encounter, Chris gets like 1 billion messages
Right.
for each patient.
Right.
So every time they have a lab result or get a whole new set of stuff.
Next slide. Another topic we get into in more detail, kind of if and as the conversation goes there. One example of where CRISP kind of has naturally evolved is with SDOH, screening and referral. So a couple years ago, there were discussions at MDH and probably everywhere, quite frankly, around what's the right way to drive assessments, screening and referrals for all sorts of health-related social needs. Our opinion, and I still think it's the right direction on this, is that you want to first focus on interoperability. Health systems, health departments, practices, kind of everyone buys IT systems that they want to live in, work in, and use themselves. And we're not trying to compete with IT systems that that Kaiser purchased, for example. So the first thing we did was to drive interoperability across systems. So taking an assessment that was done at a MedStar hospital and putting it inside of CRISP so that if anyone queried that patient, you could see the prior assessments and any abnormal values. But knowing that not everybody has every system or has any system, we did build tools that enable assessments and referrals and then close the loop on referrals. And then all that information kind of flows within CRISP. So this is maybe one area where we do have a fair amount of assessments going through. We did this for the MOM maternal opioid misuse program. There are a number of Maryland primary care practices that are pushing referrals through this program. But it's maybe a great example where the technology is more or less in place. It's really now a policy and prioritization question. So what do we want to do with it? This does also include consent. So if someone wants to consent into SED treatment, we have HIPAA authorization capabilities as well. Yeah.
Can a person selectively consent to some encounters, not others?
No.
It's all enough.
Correct. Yep. So the question was about consent. Are you all in or all out? And actually, the reason we can move down this path is with the new HIPAA, the FCD 42 CFR Part 2 updates. We didn't have to have it be provider-directed specific consent. It could be a global authorization.
But like mental health information is
Segment.
people different.
Right.
How about reproductive health?
STIs.
That's tricky.
So that has been, so we do, that's
Some
been,
other states.
so there was a law passed, as probably most of you know, to block certain sensitive data types. We do have the ability to segment and redact what are considered sensitive codes. So we are doing. Now, that said, there's probably a lot more discussion around what should be a sensitive code, how robust can redaction be, because I can't block a clinical note, for example, even if something else was in a diagnosis code. And I'm not sure any patients are in these conversations on a routine basis for like meaningful patient consent. But the technology exists. Let's do the next slide. It's just a screenshot of how information is displayed. We can keep going for the sake of time. Yeah, let's do the next one again. This is all kind of the screening and referrals. Sorry, let's click a couple more, Mina. One more. Let's do one more. So the next couple slides here are just talking about kind of that CRISP is not only, like we are an HIVR technology provider, but we've also kind of been a neutral collaborator for the state for quite a while. Kind of I joke that the reason we got into these broader activities is because when the Maryland model was first being renegotiated in 2014, you had hospitals on one side and regulators on the other side of a table kind of talking at each other. And then CRISP was like on the third side of the table. And well, the hospital said, well, I don't trust the regulators to have all the data. The regulators said, well, I don't trust the hospitals to self-report the data. And they kind of said, well, how about CRISP does it? And so we're actually at a really nice place though, where kind of no one's arguing about the data. They're arguing about what's the best policy, what's the best payment mechanism. Right? It's kind of like chess. Everyone knows the rules of chess. Everyone has the healthcare data, but it doesn't mean that you can't be strategic and do important things with it. So this is just examples of kind of different ways that we're very much aligned with and part of the current total cost of care model. And then I think part of the reason why Maryland can be really confident as we move to the ahead model. Let's do the next slide. So the health data utility, I probably with this audience should have started more with public health. But there was that law passed a couple of years ago to really identify, to designate the HIE as the health data utility, which did not like really formally create new powers, but I think it did acknowledge the fact that, the health departments are active participants in the system and that we need to share data bidirectionally more openly. We still need participation agreements. We still need data use agreements. But this is a more collaborative system now. So what that really means, the next slide, is that we are taking all that data in, we're enriching it, and we're, as we've been saying, right, normalizing, deduplicating, cleaning all this data. We're able to distribute it through different channels, and then most importantly, kind of the same thing that a health officer is looking at to monitor prevalence of a disease or certain outcomes across populations can be used to trigger interventions kind of across the entire healthcare system. Let's see what the next couple of slides are. I think I'm pretty much wrapped up if there are more questions. Here's a couple examples. So there are some kind of easy ways that the HIE has been used for public health. Cancer registrars are big time users of CRISP. Actually, I think maybe our most popular users, because instead of hunting at all these different sources, you go to one portal, which I think could be true in a lot of different settings. And then if you all remember the Cryptosporidium outbreak now 6 months ago, but it was actually, this is a really good example of where we didn't do anything, which was a good thing. Baltimore City was tracking that outbreak. They had a certain number of cases. They were afraid that they didn't have all the cases. And so they were thinking about doing a citywide boil water advisory. They asked us to essentially check their math. And so we could go through our system, all the real-time feeds, and essentially confirm that their low case count was correct. We had no other indicators that it was a more kind of a broader spread. And so we prevented an action that would have, at the very least, been inconvenient. And then there are, as we talk about populations, we have a lot of kind of interesting use cases around like HIV patients who are lost to care, or pregnancy if you want to do early kind of maternal health interventions, identifying certain populations and being proactive. But I think with that, I can pause, see if there are more questions.
And you are embedded in the data working group?
Yes.
Okay. So you're in the right place.
Yeah, they got this same presentation a couple weeks ago.
Good. And the reason we wanted Craig to sort of come here for the commission is, one, so we understand the robust quality of information that's out there. Also for the working groups in particular to be able to delve into this idea, because there's a lot of crossover here, right? He's positioned Craig in the right working group in terms of making progress there. The question, of course, is utilizability of this data across the board, right? And I think that was a key feature of why we wanted everybody to hear about this. In your wildest dreams, right, if this commission were to make major changes, and again, I'm not here at the stage right now of saying, here's the final recommendations, but where should we be going vis-a-vis CRISP?
Wow. So there are at least two asks that I would love to have. One would be kind of as we establish what we think are the strategic measures or interventions or populations of interest or something. I would love for you all to tell us, give us some measures and then drive interventions. So if we decide that, maternal health is critical, then let's get some top line maternal health measures, and then let's, actually, notify clinicians or do follow-up care or referrals or something to drive the actual healthcare interventions, not just the measurement. The more wildest dream one is that kind of the same system here that's linking all this data could link other data too. And so if you wanted to do something like prevent someone from being discharged from a hospital who was just evicted from their home, we could maybe get housing authority data. Or if you wanted to automatically enroll somebody into SNAP or WIC while they're already with somebody, you can talk to them, then get us enrollment data. These are much bigger hurdles. And again, it's not technically like MD Think is a really capable shop. It's really a question of the policy and then a lot of deliberate thought that needs to go into this because not everyone should see everything. But that's where I would really say the frontier of interoperability should be.
That's really for the local health departments, for the folks, the public health leaders, not for the technology.
So Chris just said that's where you all need to lead, not the technology.
Yes, Maura.
Yeah, I think that's it's one amazing, the evolution of CRISP, 2009 now that even we're talking about this. That's the linkage between healthcare, right? This is healthcare data. So how do you utilize it for population health, for public health? I don't think we're there yet. figuring out how to do that. Individual care, you're getting better and better at, but I don't think there's strong linkages between, like I said, healthcare and with public health.
Yeah, and there are pockets, and this is maybe another thing that will come out of these discussions, like Healthy Howard and Howard Community Hospital. Like there are groups that are saying, we're going to leverage our healthcare system to drive better health in our community. So there's certainly a lot of pockets of really good work. I think a question is, how do you, is there a systemic approach to that? Is there a global lessons learned? Is there a more deliberate way to do it statewide?
Because you have to link then, let's just say the hospitals are high utilizer, right? And the hospital is how do you leverage hospital systems and public health to truly work together and reach that.
And we have some questions online, I think, what's that? Nicole Rochester, please speak.
Hi, good afternoon. Thank you, Craig, for that great presentation. I had two questions. The first question was going back to the data elements that you mentioned. Could you tell us the categories that are currently being used to describe race and ethnicity? And the second question is, are you all analyzing any of the data by language?
So I can get you more detail on race ethnicity. I believe it's like the 7 kind of federally designated categories, which are the same ones the hospital uses. So it's not a very detailed hierarchy of race or ethnicity, which again is it's a technology lift to expand, but it's also a policy question about what's the consistent way to ask that information. And then, I'm sorry, what was your second question?
The second question was language. Mhm.
Yes, we do not have a lot of language data. That again is one of those pieces of data we would love to get. And I know Medicaid had a lot of interest in getting preferred language data, but it has not started flowing to us.
Thank you.
Sorry, is that because it's not a question that's standardized in hospital inputs that are needed to send patients?
I think it's both. So the question is that because it's not standardized for inputs, or is that something else? I think it's both. It's both in the sense that I'm not sure it's standardized or being collected with a lot of consistency. But then also, in order to get the data, someone has to go back to the 1,000 sources, probably 2,000 sources we're connected to, and kind of ask for that next, which we're happy to do, but it's faster if it's kind of a global push.
I have a question too, but the commissioner.
All I had is Rosalie Bite is a work group member, is that correct? We can ask. Rosalie, do you have a question?
Yeah, I was wondering, and thanks for this presentation. Does CRISP or a client of yours use the data to monitor for unexpectedly rising trends that nobody thought to monitor for before? And if you don't do that, I would like to recommend it.
Yeah, so the answer is no. I'm going to answer with a little more nuance. CRISP does not. Did you all hear the question? It was about does CRISP proactively monitor trends, essentially in the data. CRISP doesn't really do anything. Like what we do is use the data or provide the tools however we're told to by people who are allowed to have the data or use the data. We have talked to the secretary, and I think she's very eager to use the data to capture trends, to look at things early, to kind of make sure that there are not patterns that one wouldn't expect, or as you kind of intervene somewhere, you don't have an issue somewhere else. But we're not proactively doing that now. That would be a great ask. We get some definition around it.
Great. And then one last question we'll have from Mina here.
Great. So my question is, what's the plan for ambulatory data and gathering that from primary care and urgent care centers, for example?
So we actually have done a really good job in the past probably 5 years with ambulatory data. So typically if you're a health system and you have any kind of affiliated practices on the same system, it's all coming through. And then the Maryland Primary Care Program had participation in CRISP as a requirement. So, the 700 practices in that program are all contributing data. We're doing better with specialists. We do So Maryland's probably the only state in the country that has a essentially full image exchange also. So diagnostic quality images are available in real time through CRISP. So if you're doing like an emergent read because someone had a potential stroke in Western Maryland, you need it read at Johns Hopkins, they can do that in real time. So things like that are driving different specialties. Cardiologists are more engaged than they were a couple of years ago. But we should look at if there are gaps in participation, we should look at finding them and then reaching out to them. Urgent care has always been a little gap because typically if you don't have kind of a longitudinal relationship, there's not a ton of value.
Well, and actually, Mike, it's the, from a public health perspective, that ambulatory data is pretty incredible when it's aggregated. And so it's helpful from a diagnostic and treatment perspective of a clinician. But it's also, is there a way we can utilize that more in the public health sector?
I think there probably is. We actually, Dr. Bennett, the relatively new DC health officer, essentially asked about surveillance. And we said we would love to do that, but we get nervous around sample sizes and kind of what the right way to do it is. And she said, anything's better than what I have now. Because she's making estimates with 10 patients in a ward as opposed to kind of better data. So I think there's a lot of opportunity if we're willing to, again, like be really clear about where are the risks and opportunities and kind of what our data can do versus maybe what traditional data did.
Great. Well, let's give Craig a hearty Maryland Commission on Public Health. Thank you. Way to go. And thank you for that information. And you're getting applause online as well. I'm just saying. That
Well, I'm around. You all know how to find me. So
okay, so Craig just said he's online. We know how to find him. And I think this is a critical piece to what we're blessed by having this resource here in the state of Maryland. And the real question at some point is to make sure it's being utilized and that we as a commission, that work groups are thinking outside the veritable box of how do we take this, make this data more robust. We have a system that's functioning, right? And yet we can certainly make that, sort of change as Maura had mentioned, the change between healthcare and its use in the public health model, right? That's the real excitement here. And boy, we can wow the rest of this planet if we do this right. I mean, this is so cool. So I'm going to contain my enthusiasm to some extent because I am the chair and there has to be a certain amount of, gravity to this situation. So therefore, Mina, are you going to introduce our next speaker or are you doing too much? Because I would like to give a special shout out to Mina, our co-chair, who somehow magically has become our IT coordinator as well. We on this commission are proud to wear many hats at once. Okay. Mina, are you going to do it or you want me to do it?
I can switch with you too.
Okay, great. I might be echoing for those in the room. Sorry. Hopefully everybody online is able to hear. Wanted to introduce Deputy Secretary Alyssa Lord. Alyssa Lord is the Deputy Secretary of Behavioral Health for the Maryland Department of Health. She's joined us recently in the state, coming to us from New York. I think New York, New Jersey, where she has prior experience as a vice president, I think, of healthcare strategy for a large nonprofit that handled the behavioral health, substance use, housing needs for individuals who were homeless or unstably housed. She also has prior experience working with medically complex individuals or patients with multiple behavioral health needs and prior experience also establishing school-based health centers. So we're really lucky to have her here in Maryland. She brings a wealth of experience with her. And thank you, Alyssa, for being here today.
Thank you so much and appreciate the warm welcome and appreciate the work that the Commission on Public Health is doing. So yes, my background is deeply rooted in community health and public health. So this is very much near and dear to my heart. So walk through a couple slides with y'all today in terms of what we're looking at doing in the state of Maryland, with many of you on the line and in the communities to support the build out of behavioral health continuum of care. Can I ask go to the next slide, please? So what you see here is the behavioral health continuum of care. And some of you may have already heard this, but for context, when Secretary Herrera Scott joined the department about a year ago, she asked to take a look at our utilization data. So basically the who, what, where, when, why, and how of Marylanders were accessing behavioral health services. And this was inclusive of mental health and substance use services, and mapped out across what you see here now, the continuum. And so it is really reflective, utilizing a data-driven approach for us to understand what are the types of services that Marylanders are utilizing, as well as identifying gaps and opportunities. There's a second piece that is not included here, where we translated that claims and utilization data into what we call, for lack of a better term, our white space analysis, where we mapped by county the different types of services that were being deployed. And actually that white space analysis is on another commission website, which is our Commission on Behavioral Access and Treatment. So recognizing that there's probably a fair amount of cross-pollination that occurs between many of these commissions. But that being said, where we've landed is, as you see, we have these core foundational pillars, which are comprised of data, quality, health equity, and workforce. And those are the underpinnings to support sort of our least to most restrictive avenues to care. So ranging from prevention promotion to primary behavioral health and early intervention. In those pillars is also where we're doing a fair amount of our work around children, adolescents, and families. Urgent and acute care is actually a new pillar for the department, and we are very, very excited. We have and actually let me just take a step back on the primary behavioral health. Joining us today is, and it's only her second day on the job, is Laura Torres, who has joined us as our Director of Primary Behavioral Health and Early Intervention. So we're thrilled to have her on the team. She comes to us with a vast amount of experience in deploying community-based behavioral health programs. And so really excited to have her pick up the ball and start running with it. And then for urgent and acute care, we welcomed Tanya Schwartz to our team. And we are, I think the press release went out from the governor's office. If not, we know it's on its way. But we are about to announce more than $13 million in investments in crisis. And that's inclusive of mobile crisis and crisis stabilization centers. And then last but certainly not least is treatment and recovery. I think the other thing to call out on this continuum is that there's meant to be fluidity, that these pillars aren't static, and that individuals and their families or even communities may enter or exit these services at various different points. And so it's really about thinking about an individual or a family or community's journey to wellness, recognizing that there is a full cadre of services that we need to build, sustain, or optimize to demonstrate better health outcomes and better health equity. Next slide, please. So in doing such, this is an example of some of the ongoing work that's happening. And this is a drill down into the work that we're doing on the behavioral health continuum of care for children and adolescents, and recognizing my own snafu that this also doesn't include families. That's one of my big hangups, and we'll talk about that in a minute. When I joined the state, we talked a lot about children and adolescents, but I often found the word families, very broadly defined, was not included in how we were thinking about rendering a comprehensive model of care. So what this is a mapping of how we're thinking about service provision for children, adolescents, and families, and the different types of programs. The other piece I want to call out, that care is local. And so we want to be mindful of what is being stood up in Charles County, for example, may look different than what it looks like in Garrett or even then in Anne Arundel. So we need to take into consideration that there should be sort of core tenets of programming, but the staffing, hours of operation, those types of things, we very much look to our community partners to help inform. So these are the types of models that we're going to continue to build out. And we also have some modeling that we're doing on the adult side, but just wanted to provide you all with a snapshot so you can see the level of detail that's going into building this plan for how we render a continuum. Next slide, please. The next couple of slides, I'm going to focus really on the next 2 slides really is focusing on what are our priority areas. And I think this is reflective in terms of where we've seen investments from the Moore Miller administration as well as from the secretary. So, and with that, I do want to acknowledge that it is a rarity in which we have a federal government and a state government that could not be more supportive of the work that we're doing around behavioral health. There was landmark funding and investment that was made by Governor Moore and Lieutenant Governor Miller in the fiscal year 24 budget, with an additional investment of $107.5 million to support behavioral health services. And so much of those dollars are helping to build the infrastructure and expand the infrastructure for behavioral health. So drilling down, and again, we've tried to align this with the pillars that I shared with you on the previous slide around the continuum. A lot of work that's being done with suicide prevention and problem gambling, veteran services and peer services. We hear day in and day out the value that these services are bringing. And we are also working, I will say, across the entire continuum. We are working very, very closely with our sister agencies, particularly Department of Veterans, DHS, and DJS as well. And for primary behavioral health, our children, adolescents, and family strategy, we actually released an RFA not too long ago and are in the final stages of selecting a vendor who will help us build out not only what the strategy should be, but how we consider operationalizing. Oftentimes, we spend a lot of time talking about the strategy, but not what it will take to move forward and implement. So we're very eager to kick off that work, and that will require multi-stakeholder engagement. And then I mentioned the work that we're doing around urgent and acute care. So mobile crisis and crisis stabilization. This was something that we had hoped to launch last year, but we are indeed launching it this year. And we are expanding our teams. I think the goal is to get from 19 mobile crisis teams from 19 to 34. That is our overall goal. And hopefully in future state, we will be able to extend beyond that if the need is warranted. And then for crisis stabilization centers, this is really an opportunity to think about how are we abating the emergency department and inpatient stays and create another access point to mitigate the crisis that we are seeing in our more restrictive settings of care. And so that is meant to serve across the lifespan. And we have a number of crisis stabilization centers that are currently being renovated and developed, and then a couple that will come online in the next couple of months. There's a lot of work that's being done around residential recovery and assisted living. Again, we're trying to think about what are the vehicles that we can discharge individuals into the community in a really thoughtful but more expeditious way. We do this very well for the most part on the somatic side, where we start to think about discharge at the time of admission. I think there's a lot of opportunity for how we think about doing discharge at the time of admission on the behavioral health side, but it certainly means we need to shore up and make sure that we're building the community services. But RRP and ALU is just one of those examples. And then a lot of work that we're doing around housing, such as permanent supportive housing. We have the ACES beds, which you may all have seen through our partnership with Medicaid. We're partnering with DHCD on projects that they're putting forth. So we need to start thinking about how we address the upstream factors, such as housing, food insecurity, so on and so forth. And a lot of that work is happening in our treatment and recovery pillar. The other piece that we've started to take a look at is particularly for our pregnant and parenting moms or for our dads, how are we making sure that we are not eclipsing the family experience? We have certain limitations right now with some of our residential providers, particularly for those, if they have, for individuals who have families, that if they have 2 or more kids, they can't take their kiddos with them. And so it therefore creates additional fragmentation of care. So those are some of the things that we're starting to take a look at as well. On the policy and planning side, there's a lot of work that's being done, taking a look at our licensing and accreditation process. Maryland is unique in that we are an accreditation-based licensing state. We have an inverted process where providers go, and I'm sure some of you on the phone may have been through this, where you go through your accreditation and then it subsequently comes to the department for licensing. And so we are taking, again, if we're driving towards quality and outcomes, there are some things that we need to do to take a look at our current licensing processes. And I'm reviewing every single license that comes across my desk. And I will tell you candidly, there have been some pretty significant concerns about some of the licenses. And we're looking at COMAR in particular around shoring up COMAR to give us a little bit more latitude and flexibility, and particularly in partnership with our local jurisdictions to think about how we bringing new entrants into the market and making sure that those services that are being rendered are truly built off of quality and outcomes. And that's also, as you see here, tied to the next bullet, which is around quality and monitoring. We're looking to expand our team who's overseeing licensing, monitoring, and compliance in partnership also with our locals. And then we also have, as part of being federally funded for many of our services, as well as really trying to align how we're thinking about the continuum of care, is being very intentional with our strategic plan and partnering across MDH to make sure that our strategic plan aligns with what we're thinking about in public health and what we're thinking about in Medicaid, so that we're really moving towards a whole person integrated model of care that's also starting to take a look at total cost of care. And there's a lot of work that's being done on planning and grants and making sure that we are getting dollars more quickly into the community. On the operations side, there's still some work that we have to do here for human resources, fiscal, and procurement. I say to my team, I am humbly confused sometimes by some of the antiquated processes that we have, particularly as it pertains to procurement. So for any of you, I know we have some of our colleagues from some of the jurisdictions on the line. I just want to thank you for your patience as we continue to try and optimize and streamline some of these processes. And then we have a small team that oversees the resident grievances from across the MDH facilities and at large. And they get about 2,300 grievances per year. And that team is triaging and making recommendations about next steps. So those are some of the key focus areas. And then if we could just go to the next slide, I want to share a little bit about what are some of our additional strategic priorities moving into the remainder of the calendar year. Workforce. I feel like it comes up on every call, and we'd be remiss if we didn't acknowledge the challenges that we are all experiencing around securing a workforce and a deeper bench for many of the healthcare initiatives. So this is a focus of the governor. This is actually a strategic priority of the governor's office, as well as within MDH. There is a fair amount of work that's being done around trying to figure out what is the path forward for workforce, not only in terms of building pipelines, but attracting talent and maintaining talent in the state, and also creating pathways for growth and opportunity once we get someone here. As I mentioned before, lots of interagency collaboration and partnership. Earlier today was on a call with our partners in MSDE and DHS about the voluntary placement agreements. There is a fair amount of interconnectivity across all the work that we do. And so we really just see this as an opportunity to make sure that we're aligning policies, procedures, processes, and having better experiences across the board, particularly for Marylanders who may have to access these services. And then for value-based purchasing, many of you know that this was in response to legislation that was passed last year with a fiscal year 25 go live. So we are in the process of drafting the framework as well as the RFA for participation. So that is forthcoming. And then we did not apply in 2020 for the planning grants for the CCBHCs, and we are awaiting federal guidance, which we hear will happen this summer, with intentionality on applying for the latest planning grants for CCBHCs. And there's a lot of work that's being done with our Medicaid partners to submit the waiver for school-based health services. And I believe that is out for public comment. And then, as I mentioned before, we really need to start thinking about with the information. I'm glad CRISP presented. We work very closely with our CRISP colleagues, and I think this goes maybe to Rosalie or another individual's questions around, how are we being more thoughtful and strategic with the data that we get, and how do we look at emerging themes and trends so that we are being more proactive rather than reactive. And that is an area in particular in behavioral health that I think we most definitely need to be more thoughtful and intentional. And last but not least, I think I've mentioned that we have some antiquated systems. I'd like to get us into the 19th century, maybe even on some of these things. I'll hope for the 20th and maybe 21st, but we need to have a better understanding of what's happening with technology. And that's inclusive of, we know that there are a number of states like California who've announced a number of apps to support behavioral health. We see other models that are being stood up in New York. Illinois recently partnered with Google on almost like a resource finder. And so we want to take a look at the landscape of what's happening. The bed registry was also something that was earmarked in the 107.5. We need to be able to understand what is our capacity and our capabilities for beds across a number of different settings. Right now, we have access to some of this data, but there are other areas like RRP and ALU where much of this is manual. And then last but not least is being mindful of how we consider to utilize telehealth. We know that we have seen some pretty great outcomes as it pertains to the utilization of telehealth. The COVID pandemic certainly sped up our utilization of telehealth. And for many of our patients, they see it as a way to continue to receive care when they need it. And so we're trying to be thoughtful about what are some other types of telehealth innovations that we should be exploring. And with that, I think that is my presentation. Tried to keep it pretty short and sweet for y'all.
Great, very much appreciated, Alyssa, and we're proud to have you a member of the commission. I think the engagement of behavioral health into the public health model here at Maryland is both, one, very exciting, but also so critical to the big picture items, right? And we know some of the criticism that we have is that at times behavioral health is not necessarily embraced in the bigger public health picture. But we want to make sure this commission, one, embraces it. That's actually mentioned in the legislation itself. And two, that we find a path forward working with you, with your team at the Department of Health, but also throughout all our work groups. We don't have a specific work group on behavioral health, but in essence, this needs to be thought of at every work group level is how are we approaching this? Because we all know that, we don't separate the brain from the rest of the body when it comes to public health, right? Nor do we separate what's going on in the community from, the influences of the behavioral health issues that exist in our society, right? The community is directly impacted. Do we have any questions here in the room from commissioners about this presentation? Yes, Mina.
So thanks, Alyssa. I think from the perspective of the commission where we're assessing the public health infrastructure at both the state and local health departments, could you speak a little bit to the organization of behavioral health oversight services, including prevention work, and the role of local health departments in that work?
So we can't do this without all hands on deck. I think we historically, and I'm not referring only to Maryland, I think if we're thinking about this from the public health perspective, we need to consider behavioral health as part of a public health intervention. And that requires partnership with the local health departments and the LBHAs to ensure that we are building the continuum of care. And so I think this also goes back to the point around, and part of it is based upon our current model of being a carve-out state where we've separated the somatic and behavioral health needs of individuals into two separate systems. But I think there's tremendous opportunity for both the local health departments and the LBHAs to make sure that we're building a sustainable system of care.
As you know, I mean, several of our local health departments do serve as the LBHA function, just like we serve the function of chronic disease prevention, control, infectious disease control, and investigation. So it's ensuring that our local health departments, which serve as chief health strategists in their communities, continue to have a significant role in the incorporating behavioral health as a health issue in their county.
Can you bring your phone over to Maura so that we can, this is technology at its best, because that way they can hear you there and I don't have to reinterpret things.
Hi, good afternoon. Alyssa, thank you for that presentation. My question is actually a follow-up to Mina's, a little more specificity. I'm on the governance subcommittee. So could you do your best to explain from your perspective the governance of behavioral health in Maryland?
That is a loaded question. And not an easy one to answer, right? We have a complex ecosystem that has been established, and I'm sure some of you in the room could educate the rest of us better than I could. I can only speak to what I've learned in my past 6 months, but we do have in each jurisdiction, the governance system looks very, very different. And so those are ongoing discussions that are happening. One is I'm going jurisdiction by jurisdiction to understand what is the model of system delivery so that I can learn, because we also haven't talked about the role of the LAA or the CSA or those that stand up as a nonprofit, right? So I would love to be able to talk to you more deeply about the governance, but this requires some additional thought and education around, what does the structure actually look like? There are not a lot of states that look like Maryland that has allowed for there to be this sort of different interpretation of what each jurisdictional infrastructure should look like to support behavioral health. And so, I think what I'm asking for is, or what I'm saying is there's a little bit more latitude that's needed before there will be sort of more formalized thinking about how we set up the governance structure. But again, and it's interesting in part because I've gotten some feedback from our LBHAs in particular, and I'm also hearing it from I guess from some of the local health departments, is that LBHAs are going away. And so what again, I just want to iterate that care is local. And so it ultimately requires everyone to figure out how we work together to optimize and deliver services, and whether it also means that we need to be thinking about how are we building sustainable provider networks to ensure that we're meeting the deliverables of the continuum of care. So, I think there's a lot more work and discussion that needs to happen around the system delivery model for the state of Maryland.
But I think, again, trying to be, very mission driven here, as we look at the commission and the working groups specifically, and maybe it falls under governance, Fran, right, is to really delve into this, is if it's complex, how do we work towards it? We won't solve the whole problem of complexity necessarily in the next year and a half of our work. But at the end of all this, is there a pathway, right, to make sure that this blends in more, right? I mean, we would love Maryland to be the model for the rest of the United States of how the idea of public health, right, is really taking care of its citizens at all the needs, at all the levels, right? And if we have, complexities built into our system, let's, Mr. Gorbachev, tear these walls down. Historical quote. We have one last question. If we have any other comments here in the room, Rosalie Bright, please.
Hi. Hi, this is Rosalie Bright. That's very interesting. I wonder if you are aware of the model that's practiced in Norway. They've been using it since they had the major mass shooting over a decade ago. And it's very proactive about trying to teach children about psychological resilience, teach teachers how to spot trouble at a very early stage. And they also monitor various kinds of records to identify people who are at risk of starting to need services at some point, and then they intervene early. And they have state-paid psychologists to work with kids, adults, families, to try to deal with problems as they're emerging, maybe before they emerge, and definitely not try to let them fester. And it seems very expensive up front, but I suspect they're saving a lot of expense down the road.
Yeah,
Great,
thanks. Rosalie. Yeah, thanks, Rosalie, for sharing. The only thing I'll say is that I think, Rosalie, what you're calling out is the investment that's needed in early intervention. And it requires sort of a multi-stakeholder approach to make sure that we're operationalizing and executing on that vision. And I was talking with Laura Torres earlier today, and we were talking about Head Start, for example, right? So Head Start is a great example of early intervention. And so that's actually as part of our children, adolescent, and family strategy is we're trying to be far more intentional about how we think about deploying services into the community a lot earlier, but it's not something that BHA can do alone. It requires some additional stakeholders and partners to be successful.
Yeah, and I'm sure it involves a lot more investment too.
It does
But
indeed.
I mean, it might be worth talking with Medicaid and Medicare, like, hey, can we start more up front so that we don't have to pay as much on back end? Like
Great.
law enforcement, the whole thing.
Thank you for that observation
Thanks.
and answer. One last question to Fran.
Just to say, Deputy Secretary Lord, I haven't met you. It's a pleasure to do so virtually. Appreciated your presentation. And like Dr. Rossman, I'm on the governance and organizational capability work group of this commission. I'm delighted that you're on this commission. And I'm going to assume that you and your team would be open to the kind of key informant and ecosystem mapping of governance that we're going to have to do over the next couple months to at least put it down on paper what the state and local behavioral health constellation looks like in terms of authority, accountability, and organization, and ditto for the public health side of the house, and see how you said align the strategic plans between public health and behavioral health, see how we can actually put some fine points on that. And if it means some changes to COMAR or to statute, that's what we're here to do. So I just want to thank you for your presentation and look forward to working with you in the months to come.
Thank you so much. Looking forward to it as well.
Great. We're going to take now a 5-minute break. Repeat, a 5-minute break. Please don't all rush the snack booth in those 5 minutes. Give a little space with each other. But 5-minute break, and then that'll almost put us back on schedule, almost. And then we'll make sure we're efficient for the second half of the meeting. Thank you for your attention. Those of you on the web, please stay aboard and stretch. We're going to stretch for 5 minutes. 5 minutes.
So usually we just mute it.
Yeah, I just mute video off. Yes, not the video off, but mute it.
Yeah, thank you. Yeah.
Yeah, I'm good. I'm
Really doing well. Yeah, you see, yeah. Extra hands on the technical really makes, yeah. And then it's lessons learned. We've gone through this before, right? So it's like, yeah. Yeah, but you're doing a good job. Oh my God. Good job.
Yeah. You know, I'd be able to set up, yeah. I'm gonna figure out how to do that. But yeah, you know, like,
Testing, testing. Okay, got it.
And so.
Yeah, you can hear me? Yes.
Uh,
Can you hear me? Great. There's a microphone here, and there's like. It's great. Stay on. That's.
Okay, I'm gonna say something again. We were trying to fix things up. Okay, people out there in the world of the internet, Brian, I can see you. Can you hear me? Okay, is it better than before? Are you hearing loud and clear? Okay.
Yeah.
Great.
I can't hear the echo anymore.
Awesome.
Okay, thank you. Okay, let's move on then for the second half of our meeting, and this is an equally exciting part. First part, we get new information. We have the ability to get, new facts in our brains, and we appreciate both presentations. Second half is really discussing the business of the commission and specifically where the working groups have been. The tasking at this point in time has been for the work groups to really get down to work and specifically to present back to the commission what are their data needs. As you know, we're looking at what are the needs of the data. Later on, we'll look at the assessment, we'll move into recommendation phases down the line. But specifically what we want to do, and this is a key component of this, is we're going to sort of tabulate what data is necessary from the work group perspective, making sure that we are effectively and efficiently working with you to obtain that data. The last thing we want is everybody to go off and contact the same people, right, simultaneously. That's only going to lead towards people getting really frustrated with us. In fact, earlier today, Nilesh, who was not able to be here, a member of our commission, he has some testimony he's doing in Annapolis. Just said, that he would appreciate if we can coordinate any information that we ask from the Department of Health, go through a system there, right? And that way we can keep a sense of what's being asked for, but also that we not put too much demand on what already is a stress system. So this is critical. The first group that will be presenting are our representatives from the Communications and Public Engagement Group. So, and your slides, I tell you, I just checked them out. They are incredible.
You're okay sitting up at the top.
Yes, please. These two seats.
And also, while they're setting up, I just want to say thank you to Jack from Chris, who happens to be here at the meeting today. And apparently he installed this audio-visual system that they have here at Baltimore County Department. So came in and saved the meeting. Thank you, Jack.
Get started. Good afternoon, everyone. I'm co-chairs for this work group and the health officer for Cameron County. Everyone, I'm Sylvette Latou Howard, and I'm the other co-chair for this wonderful work group. We have a really engaged and wonderful group that we've been working with. It's given us a lot of feedback on this topic and really trying to figure out what are the things that we need to understand to better move forward with communication and public engagement, local and state health departments. So we went through a number of exercises to really understand what people think is needed, what some of the challenges are, and then what script data is available to us right now. It's an area where the data, I think, is very disjointed and somewhat limited. So next slide. All right, so just so we're all on the same page, looking to understand the communication and public engagement capabilities of local health departments as well as NPH, and then for public, really understanding better health literacy, also people's perceptions, attitudes, preferred communication methods are going to be really important to determine what sort of things we recommend local health departments and state health departments should be doing, because we need to know how people want to receive information, they want to receive it from, for those messengers. And right now, we have some ideas. The pandemic helped a lot with understanding a bit more of what people don't know. They consider trusted and credible, but we still don't have a lot of data on this.
I'm going to ask you to speak up. We just got a word that it's hard to hear. So I think that.
Okay, so what we really started to look at is and trying to understand, is there any data that's available at a state health department level or local health departments that is in uniform and comparable, right? So there's different things that come up in different health departments, maybe various surveys that have happened or data that they've collected individually, but is that something that we can actually pull together and use in any sort of uniform way? So next slide, please. So what we've really started to look at and understanding the capacity of health departments, right, local and state. What is the staffing expertise for the tools available and what's the funding available to do this work? We know that there's limited, what we've heard from at least the local health departments were pretty widely represented on this group. The staffing expertise varies quite a bit in what we're looking at. And then what sort of tools are available to folks, right? What sort of social media have people who are specifically managing social media and know what they're doing, managing your website, working on your public engagement or campaigns, and understanding what the amount of funding that's available is across the board in order to increase those things. Or what are people working with? If you say, okay, we're going to do a communication campaign around vaping, right? How do you even start that as a local health department or a state health department? And where's that funding coming from? And understanding that data. So one thing that when we looked at what data is available, we know uniformly almost every county has a health needs assessment. And we pull some of this out of there. There's not really anything, at least in my time, and if anybody else knows something, please do step up. That's measuring capacity in local and state health departments for communication, right? There's no tool that says, how many people do you have working in your communication department? You have a communication department, right? A lot of folks might have a singular staff member, right? Maybe you have a PIO, call that a comms team. When people say, who's managing your social media? Hodgepodge of folks. And so that's definitely a challenge. Understanding what the capacity is across the board is something that we need to know more about. And then also understanding what sort of public engagement activities are already happening in health departments. What does that look like? Do we have the ability to have culturally appropriate conversations with the community, right? What are your translation services? What are the language barriers that your residents might be facing, and how are we presenting information? And then bi-directional community engagement is something that came up a lot in the community, not just wanting to hear from state and local health officials. They want to be able to provide information back. And how do they do that? Are there opportunities for that? And there's really not, again, when we're talking about what sort of data exists for that, these are the things that we as a committee have come up with what we want to know, but I don't know that we found any particular data sources that get at some of these particular questions. I think we could get some information on general languages spoken and the ability to translate, but that kind of just scratches the surface of what we're talking about. Okay. Next slide. So that was looking at local health departments as well as the state health department. Then there's the public, because obviously we are communicating with any entity or individual. We need to know what their preferences are, right? And right now, we really don't have a strong understanding of how the public would like to receive information. And there are various methods, but if you're looking at any particular subset, if you're going to divide it by age, race, or gender identity, then what is that particular group of individuals preferred communication method or trusted message? So next slide. Okay, so starting with health literacy, right? I think we've all got a much better understanding of what people somewhat understand about healthcare and their health, and that there's a lot of needs there, right? There's and the onus is on us to make sure that the information we're putting out is appropriate and at the right levels, and that people are able to easily understand it. But then also really understanding who they want to hear from, right? There are studies out there, we know that there's some of this exists as to who are trusted messengers for healthcare, and it's not always healthcare professionals. And so in those situations, where we put as the face of a campaign, talking to people, trusted in that community, and even if it's local individuals, how do we engage with those folks? How do you get to know who the trusted messengers are in your community? And then your communication preferences. Is it written? Is it something that you want to hear on a podcast? Is it something that you want to see on social media? Do you want to receive something, a rat card at your doctor's office? There's all these questions. Really, I started a literature review. Thank you to the folks in the room who are part of that group again at Chittagong, but really students helping us understand generally what are the ways that people prefer to receive communications. Because I think oftentimes we're missing the mark because we're doing either what we're used to, what we can do, and that's not necessarily the way to always reach folks. And then attitudes came up a lot. Because trust is a big topic. Do they trust the information that you're putting out? Not just the message. Do they believe that the information you're putting out is correct? How are you putting out a verified source? What are the sources of information? And in local public health, we're generally not generating the research. And there are layers to we're getting information from. Say, okay, this is the new CDC recommendation. But if the public doesn't trust the CDC, right, or they have questions about that, then what? And what does it look like? And that's one of the questions that's been raised quite a bit, actually, is what do you do when you're in that position? And can local public health do anything different? Or can the state health department do anything different? So these are some of the things that we've come up with as areas that we use data on. If there are other ideas that folks in the room have, please let us know. But this is kind of.
Okay, so hopefully we're all on the same page of why this information is so important. And our group also then talked about some potential challenges that we could have, and probably all the work groups might feel the same way. Next slide. So it was kind of mentioned, Boris mentioned it a little bit before we actually sat down about having a uniformed way of collecting our data, because one of the things that we don't want to have is survey fatigue, right? We know that in 2024, you're getting a survey everywhere through your phone, through mail, everything like that. And if we really want to get rich and meaningful data, we need to make sure that we're not overwhelming our potential participants. And then time constraints. So there will be a discussion, I'm hoping and I'm sure, about how long we actually want our survey or whatever methodology. How long do we actually want it to be? Thinking again about one, survey fatigue, and then how much time do we want our participants to spend with us, right? So that was another thing that we considered in terms of what do we want to know? How much time do we have? How much time are they willing to give us? And then staffing. Want to ask it now or?
It's just related to the survey, because other work groups are also going to surveying.
Exactly, and that's what I'm saying. It's probably going to be all of our concerns, because we might have to just have one collective document, but we'll discuss that, right? So we were thinking about some of those things. Then staffing, what kind of staffing will we have in terms of collecting our data and analyzing our data? We'll go to the next slide and look at some more concerns. And then incentives. We're going to ask our potential participants / respondents to lend us their time, actually to give us our time if we can't give it back to them, but to give us their time. And will there be some sort of monetary rewards for it? I think it's something that we should all consider around the room, but that was some of the things that we were considering also. And then the way that we will ensure privacy for our participants, especially when we're talking about communication and what information they would like to hear and from whom. And trust issues. I think we had 2 meetings, and in both of our meetings, trust has been one of those things that have emerged as a topic again and again. It is going to be so important for us to let our participants know that they can trust us. And this is also one of the steps in building the trust that I believe that we need to have with our local constituents. We are in a point in our history where trust has been broken, but it's possible for us to build it back. And so this is going to be one of the ways that we're hoping to do that, by hearing about that. And then, of course, technological barriers. How can we ensure that we get and hear the voices of as many people as possible? So automatically we think of sending out a survey through the phone or through the internet, but there's going to be some people who they're not technologically savvy, but their voice needs to be heard. So how will we be able to ensure that their voices will be heard? And how can we work around those technology concerns? So we know that there's a lot of information that we want. We know that there's a lot of information that we need. And I believe that if we look at all of our concerns, but also address some of the challenges, that we'll be able to, or at least determine to do so. That's it.
Great, and we'll save discussions for the end and questions for the end. I'd like every work group to be able to present as we sort of talk through path forward on this. But thank you to the presenters. The next work group to present will be data information technology, and I think Chris is going to be taking the lead on that. Is that correct?
I was.
Who is? I'm sorry. Oh, Rachel. Okay.
Good afternoon, everyone. Can you hear me okay? Just want to make sure. Okay.
Yes, thank you.
Okay, perfect. My name is Rachel Budwani. I am the work group coordinator for our data and information technology work group. I'm presenting on behalf today of Jay Atanda and Matthew Levy. So I would just ask that any questions at the end, I will definitely jot them down and give them to forward to them so that way they can respond on behalf of the work group. Next slide. So for our presentation, we have objectives, data needs, barriers, vision, and goals. Next slide. For our objectives, it assesses the foundational public health capabilities of state and local health departments and analyze the state's ability to respond to major public health challenges. Next slide. So for data needs, we actually met with several members from Maryland State Department of Health, I think it was last week. And so we were able to get a better understanding of where the data needs currently are. And so there's been a project for the last few years where they have been conducting an assessment for the state data needs. So what they found is they produced a 2021 inventory report that kind of had a honeycomb diagram of all of the different systems that are being used at the state level. And so we had a really collaborative call, and what we found out is that they were able to complete a pretty robust assessment at the state level, but where we're hoping to do a phase 2 and kind of pick up the work is integrate the local health departments and continue the assessment at the local health department level. And so we're going to be having some of those key stakeholders that participated in the original assessment participate in our subgroup that will be developing the assessment for this work group. And so they did share with us the 2 tools that they used, which is an evaluation framework for health information systems, which is Human Organization and Technology Fit Factors, or HOTFIT, which information that can be found on PubMed, and PHII's Informatics Savvy Health Department Self-Assessment Tool. So those are going to be the main things that we use moving forward. So from that discussion, we looked at the data needs that they've mostly identified and some that we found in some literature reviews as well. And that's what is populating this section right now of the data needs. So data system enhancement and transformation, so unified statewide EMRs for LHDs, interoperability of LHD systems with external systems, which also includes systems that feed data reports into the state and local health departments, such as hospitals and maybe some FQHCs and et cetera. Integrate public health data systems, so linking the clinical and public health data and siloed public health data systems. Next slide. Some other needs that we have identified are open data. So the need, especially with the development of more AI and Copilot and ChatGPT for data security to help monitor and track cyber incidences, data accessibility for extrapolation and research, IT governance framework to guide data use and reuse, and then data to action. So really picking up on what Chris was presenting with the care coordination, the auto enrollments, auto benefits, and data informed policy making. Next slide. So some barriers that we have identified as financial, funding support the needs in prior slides. So that also includes making sure that funding is equal and across the different local health departments for all the needs that are identified as well. Capacity, so workforce development, equity, again, consideration of how data is collected and used, and legal barriers, which is a big one right now with data sharing and use and reuse of data. Next slide. So in order to develop our goals, we first set vision, so that way we can kind of lead us to help frame our goals for the work group, which we identified assesses the state of the current data and technology systems used by the state and local public health and their effectiveness in meeting the needs of Maryland residents, and analyze the quantitative and qualitative assessments to make data and technology modernization recommendations to Maryland Department of Public Health. Next slide. Public health data and information are treated as statewide assets and are readily available to support evidence-based decision-making and data-informed policy-making to best serve Marylanders and move the public health community from siloed and brittle public health data systems to connected, resilient, adaptable, and sustainable response-ready systems capable of meeting today's and tomorrow's health challenges. So some of the vision that we discussed is pulled from other vision statements from other organizations that have already started data modernization as well. So like Indiana, other literature review populated vision statements. Next. So for our goals, our co-chairs wanted us to use the word that these are living goals. And so as we continue to kind of dive deeper into our assessment, we're kind of keeping a mind frame within our work group that this is flexible and fluid. And so these are the overall goals that then we plan on breaking down into more measurable action items and milestones for us to kind of make sure that our assessments are feeding back into that loop of these goals. So our goals for the data and IT work group are integrate and coordinate public health and clinical data across health and human services entities at the state and local level, ensure access to actionable data, tools, and resources that drive evidence-based policies, cutting-edge research, and coordination of care across involved entities, and maintain the highest level of privacy protection throughout data security and streamlined consents. Next slide. And lastly, our last two goals are create interoperability by providing a uniform electronic health record system and standard tracking tools for immunizations, vector and communicable diseases, environmental health issues, social determinants of health, and other foundational Maryland Department of Health and local Department of Health needs. Accelerates access to analytics and automated solutions to create efficiencies in public health investigations and advance health equities. So that's all that we have. The last slide for us is if you have any questions or comments, please direct it to our health officer. Thank you so much.
Great. Thank you so much, Rachel, for that presentation. Next on our line, our listing is funding, and I think Larry's taking this on. Larry?
I am kind of out of default. So I'll keep it relatively brief. At our last meeting, we had a pretty in-depth overview of core funding. Core funding formula has not been revamped since the previous century. And so we also talked about some potential ideas to modernize the way that core funding is done and possibly how core funding can be expended. We also talked about some just basic payment issues with local health departments and at the state level in terms of federal and state grants, billing for clinical services, and especially given the populations that we treat, which are predominantly Medicaid insured or self-pay, which no private practice could ever actually keep their doors open if they had that kind of payer mix, local government appropriations, and then fees that we collect through environmental health inspections, birth and death certificates. So looked at a little bit of an overview of both primarily at local, but also to some degree at state level, how funding occurs. And then we talked a little bit about where we would like to go over the next few meetings and topics we'd like to cover. So one of the things that came up was, is there a place for public health funding within the next iteration of the CMS waiver? We're all aware that no longer is this funding supposed to be isolated to hospitals or within hospital walls, but it still seems to be controlled solely by hospitals. So for things like population health, care coordination, it seems to make sense at this point that if we really want to drive down disease incidence and prevent overuse of emergency rooms and other hospital services, that it would make sense to potentially consider public health as part of that planning. So we don't know if that would be feasible, but that may be an avenue that we want to advocate for. At our next meeting, We're having a discussion on community benefit dollars. There's a discussion tomorrow with the COO of the Maryland Hospital Association. That's sort of a prelude. Likely representative from MHA will join our discussion. And then I've had a couple conversations with academics at Hopkins who do research into community benefit dollars. They're taking a look at other states and seeing if there might be any models that would be useful in Maryland. I also, we've been a little understaffed. We haven't had any CDC help. So I traded my co-chair for some CDC help. So we finally, we have somebody now who's going to help to do some research, and she's going to start to take a look at how other states are potentially looking at novel ways of funding their public health sector, and also take a look internationally at countries that tend to do a better job in health metrics and how they allocate their money between clinical care, clinical medical care, and between what we would consider true public health funding. The trick there is going to be trying to compare apples to apples, since so many things can potentially fit under a public health basket. But we're hoping, again, to take a look both internationally and then other areas of the U.S. to give us potentially some models to pursue. So that's all I have for the moment.
Great, thank you so much, Larry. And next up is governance and organizational capabilities. Fran, I believe that's you. Yeah, great.
I do this knowing that I have many very capable members of the work group in the room, okay? It's a little daunting. So it's Julie and Laura and Nina. And I think that's it, but I know several are also online. So very quickly, you got my slides, right? Yeah. Okay, all right, so let's go through, let's just skip the mission statement, okay? Because I just want to get into some of it. Okay, so let's go to the second slide, which it's sorry, we're having a little. There we go. Okay. All right. So our that's going to be this. Our work group had had to go through an exercise first. And
Microphone. Turn the volume all the
way down. All right. We good? There you go. Are we good now? Right again? Ha. Okay. Online over here. Michelle. You hear Michelle?
It's a little difficult. It's a little muffled.
Where is the microphone? Oh.
Oh, yeah, I'm not going up there. Okay. I'll do my best, Michelle. All right.
Okay,
so,
that's better. That's better, Fran.
is that better? Okay, okay.
Thanks.
So our work group, before we dove into the data questions, into the assignment, we had to do some soul searching about what it is that governance and organizational capabilities really entails in this whole constellation of public health. So had lots of very fruitful discussions about what's our scope, as well as the other items, the other questions, the more binary questions on the rest of the slide. We came down on the a broader rather than narrower scope question, so that of course it's public health services that Nilesh gave a presentation on. Of course, it's the local health departments, but we also include in our scope, thinking broadly about public health, we include behavioral health administration that we heard about today. But because of the such strong influences and impact that Medicaid has on public health in Maryland, as well as has been mentioned, the total cost of care that's administered, models that's administered by HSCRC. We felt like they are important influencers to talk about governance and organizational capability. Also, Maryland Department of the Environment, because local health departments take direct statutory and regulatory authorities from the Maryland Department of Environment. So our scope is pretty broad. Not to say that we're going to do everything for all of those entities, but we wanted not to let any of them drop off our radar. So then we had some more discussions. Are we doing aspirational, how we really want this place to look like, or are we going to be more pragmatic and look at what may be feasible as far as incremental accomplishments, looking at some short-term goals, but always leading to some broader systemic change. The last thing is we heard from Indiana. We've looked at all that business. I know you guys, some of you went on a site visit, but you know, we have this idea of uniqueness in Maryland, and it's not unfounded. There's a lot of things that are very special about Maryland that we thought it's going to make it a little tricky to benchmark ourselves against some other states. One of them is the fact that MDH is a super agency. So MDH has behavioral health, it has Medicaid, and has public health in the same agency. That's not typical across the country. Secondly, Maryland is the only state that CDC has characterized in terms of governance as being largely shared between state and local. So we're the only state. Some other states, there's 4 other states that are somewhat shared, but we're the only one that has this kind of integration as far as leadership, as far as funding, and I think that's pretty unique. We heard about how unique we have a health information system here that is second to none and has unbelievably still untapped public health capabilities. That's all good stuff. We would be amiss if we did not say that we have some outsized disparities in Maryland that are persistent and that they are front and center of our public health agenda as far as equity. And so benchmarking ourselves to some other states, maybe in some domains may be useful, but that really needs to be selective about that. So if you want to do next slides, that would be great. So data needs. All right, so you know, we've got a lot of questions here. You can see that as you kind of work your way through the questions, we have a lot of questions that are qualitative. Let's start at the first one. This is a cut and dry one. This is empirical. This is what is the law and what are the regulations that govern state and local public health. Okay, so that's in law, and we're very fortunate on our work group to have a professor from the University of Maryland Law School, and she has done all this work to categorize it. So we're going to be on really solid, very timely ground as far as that piece of data needs. The rest of the items on this needs list are much more qualitative, and they have to do with opinions. They have to do with key informant assessments of how it's really working. So we call there are 4 core governing authorities with respect to public health in Maryland. Actually 5 if you include the governor. All right, so we didn't include the governor. We should include the governor. We did. We'll include the governor on the next slide, on the next version. But MDH, secretary, Maryland Department of the Environment, secretary, who's ever is in charge in local governments. And sometimes that's commissioner, sometimes it's executive, sometimes that's all together. And then the local health departments have local boards of health. So these are 4 governing entities that oversee public health. And so think about how we can assess how well are they performing. That's going to be really up to some qualitative, very carefully designed key informant interviews. And perhaps if any of you have some suggestions, that would be terrific. What's the nature of the state and local relationship? And so there are both formal and informal channels of policy development, of communication between state and local health departments. And we can map some of that, some of the formal channels. Some of the informal ones are going to be a little bit tougher, but we're going to give it a try. So leadership, number 4 speaks to leadership. And so we've got some statutory requirements as to who can be, for example, a health officer. But let's take a look. Let's take a look at the current demographics. Let's look at the map of Maryland's public health leadership and see what we've got in terms of demographics, qualifications, and performance. And are there elements in the underlying history or culture of public health in Maryland that are skewing or are showing us that we've got opportunities that are untapped for leadership in other areas with other communities. Lastly, this is all related to the same thing. How is the whole governance structure, how's it doing in terms of advancing equity and advancing quality improvement? So these are big questions, but we've got some data sources for answers. So let's turn to the next slide. The quantitative and empirical ones, you don't need to read all that fine print, but well, you should, because you might be listed as a key informant up there. We took the liberty of proposing some data sources. Some of them are very straightforward, as I said, the law, and others we can get data. We think from MACHO, the Maryland Association of County Health Officers, from as we said, from MDH, looking at the profiles of state and local, the organizations, the local boards of health, who comprises the local boards of health, and how often do they meet? In most cases, the local board of health is the governing body, maybe the county commissioners, maybe the county executive plus the county council. Let me tell you, these elected people did not run for office so they could be on a board of health. Okay, a lot of them, when they got into office, they didn't know that they were on a board of health. So there's a lot of education that needs to get done for these people, and really importantly, do these people, in their role as public health governing body, do they represent the community? Okay, so if you have a commissioner and they're at-large elected, how are some minority and underserved populations in that county going to be represented by an at-large commissioner? We just have some things that we want to look at in terms of the composition of these entities. I want to jump down to the qualitative. I'm not going to go through all of this, but we do have some ideas about individuals and groups to interview. We really are going to need some help on designing these interviews, on the ground rules for the interviews, in terms of eliciting some intel on some topics that may actually be sensitive. So we are going to absolutely need to understand, have some confidentiality agreements, and give people some space, some safe space in which they can report some anonymity. So the next slide shows some of the potential data sources for key informants. And you can see it's the whole spectrum of what we call the core governing authorities. Of special note is the principal attorney general. There's the principal attorney general, the lawyer, the top lawyer for Maryland Department of Health, and there's one for MDE as well. They have a team of lawyers there at MDH and MDE, and they help local health departments when there are legal issues. And so I think that they will have. Fortunately, they're not represented in the group here or in the work, but we can find them, and I'm sure that they'll be very willing to talk to us about some of the statutory and regulatory strengths and weaknesses as well. So last slide is to talk about the challenges. All right, so time and resource, we talked about that. We talked about the methodologies. We don't know how to do this, so how to do a qualitative, how to collect and analyze qualitative data in a meaningful way. And thank goodness we have Julia on the work group. We need some more expertise in that area. Obviously, we need to work with all of you and the other work groups, because we're going to get a lot of survey or interview fatigue. We do not. We're going to ask for the cooperation, and we realize that there's going to be some sensitivities around this. The last slide, and I'll end here, is that from some of the there's one more work group to speak, but I'm hearing our scope might even get a little broader. But we'd like to put back the questions to you all on the other work groups. Just look at number 1, because it covers all the work groups. How does the current governance structure impact funding, workforce, IT, and communications? So if you have an opportunity to include that in a discussion in an upcoming meeting on your agenda, that would be really informative for us to get your views on how you see the governance and organizational structure could be augmented to improve performance. So with that, we got that.
Great, thank you so much, Fran. And now we'll move to our last work group. I think Brian's going to be covering workforce.
I am, thank you. And we can just move to my slide. I have one slide, thank you. So workforce really needs data, and was a major component of the Indiana work, was having Indiana University, Purdue University produce that workforce report. And so we can duplicate that. It's going to take a little bit of a lift. And so when you look at the NACCHO profile that's just coming out, unfortunately, not many health departments participated in the profile survey. Now, a profile survey is really at the organizational level. So this is questions about the health department. What's your budget? How many vacancies do you have? Do you allow telework? Those are organizational level questions. We believe that with the help of the health commissioners who are on the Workforce Commission and others. So we pulled the data and we did not find that. So we will follow up on that note in the chat and see why the disconnect is when we talk to our counterparts that run the profile. If that profile is already there as a requirement of NACCHO, that's great. We can then move to the individual level data. The Beaumont Foundation every 3 years does the Public Health Workforce Interest and Needs Survey. Previously, we have limited it to states and certain locals of certain size. The public health WINS data are now being used to evaluate the impact of the Public Health Infrastructure Grant, and we are allowed this year to go to any health department of any size. We are launching the survey in September of 2024. We believe if we can get all of the health departments in Maryland to participate, we would have an unprecedented set of data. These data get you information such as intent to leave, reason for intent to leave. So some of the information that's just not collected in a profile survey. We've used these data nationally to document the fact that half of the public health workforce turned over in their position between 2017 and 2021, and 75% of that workforce, 35 or under, turned over in that same period of time. So this is more about signing up the 24 health departments to all participate in PH WINS, and if there is a need for economic incentives, that's something that we may be able to do through our resources at Beaumont. And then lastly, we're going to want to do qualitative interviews with each of the health department, each of the local health commissioners, with up to 2 people of their choosing using a standardized instrument. So we're going to do this mostly with interns, students from Hopkins and UMD, some of the researchers who are on our workforce panel, and a contribution in kind from the Beaumont Foundation. But we believe that the report that we can produce and the information that we can create will be not only useful for the commission, but useful for several years to come, and hopefully something that the legislature would want repeated in future years. So that's what I have to share from the workforce group.
Great, thank you so much, Brian. So before we open up for discussion and sort of pass forward on this, I do want to congratulate each of the work groups. Mina already wrote me a special note saying this is really incredible. And it's only been a short time period. I know not a lot of meetings, And let me just, put in that plug that, we are so blessed to have the work groups that we have, the leadership that we have. There's a lot of lift ahead of us here, but this is pretty incredible, right? To have this already in a short amount of time. Let's open up to discussion for people to comment on this. We will take all this information and obviously try to coordinate, where we have overlap and make sure that we at least have a roadmap from the commission's perspective and leadership perspective to the work groups to be able to push ahead and to be able to make sure we do this in as a straightforward manner as possible, although there are undoubtedly complexities in here already. Any comments?
I have a question for Brian. I just regarding the last statement about interns assisting with their survey distribution. I heard Hopkins and UMB, but I know that we also have interns from Morgan State and Coppins. I just want to make sure that those interns are also utilized to assist your work. Can you just confirm that they would also be assistant? Thank you. Oh, you have to leave it. Okay. Okay.
Sorry, I was on mute. Yes, we confirmed that. I've asked Michelle to help us pull together all of our interns that are assigned to the committee so that we can start to assign out tasks.
Thank you.
I have a quick question for workforce as well. Maybe I missed it. I'm also considering survey for the centralized organizations like MDE, MDH.
I'm sorry.
Maybe boards of health, because it's, again, as related to the governance structure, it's not just local health departments in Maryland. There's an intertwined relationship of many organizations.
With the individual level surveys, the unit of sampling is the local health department. We will be able to include governance just from existing information into our analysis. But when you look to do either the NACCHO profile or the PH Wins data, the unit of sampling, the unit of analysis for the profiles of the local health department, the unit of sampling for PH Wins is the health department, and then that's an individual level survey. Does that help?
Yeah, I would just suggest surveying both MD, I don't know what do we want to call them? And the central structures, MDH, MDE.
Oh, I'm sorry. I apologize. The central structure, the Maryland Department of Health, has participated in the state level PH Wins since it started in 2014, and they've completed the ASTO profile. So statewide, the data are fine. We have really strong data. It's really complementing that with the local. And again, I'm glad to see that Ruth is telling me 100% of Maryland LHDs participated in 2020 LHD profile, because then we just get that back from NACCHO.
Thank you.
Yes, Brad.
Thank you. I have a question for the data group. It's a great presentation. Kind of given me heartburn though about what you didn't talk about, because I think that might be in our scope. Okay, so your presentation was about public health data, whether it's clinical data or population health data. That's the heart of it. But there's also these data systems that have to do with fiscal management and HR and procurement, grants management. These data systems that are internal. They are not external as the ones that you talked about. And so we can't let them fall through the cracks. We got to deal with those things. And if you all aren't going to do it, I think it's real. Would you guys agree this is in our scope? I just noticed that and I thought, wow, we can't overlook the financial management system in the state of Maryland, right?
I completely agree with you. And these are definitely the systems that are in place, as well as the lack of interoperability in many of the systems. That is part of what prevents us from fulfilling our full potential.
Right, and somehow just get on our radar, but I guess it's on our. And the interoperability that Mina's talking about is that the state has a system and both governments have a system. And so, we'll take that up, you know, work group meeting. Okay.
Right, and this may be an area of shared, you know, assessment, right? Like the data and information technology work group, I think is looking at questions of interoperability and is looking at questions of all the different data systems that were mapped out and shown in the honeycomb that I should show before in this presentation. But you know, I'm not quite clear if that honeycomb demonstrated, you know, Workday and EMS and all these other archaic systems that we utilize in the state or at the state health department around the clock that are also in play. Those were just systems about actual collection of clinical data sets or public health data sets that either in the state or
The only other point that, thank you, that I make a suggestion to our co-chairs for some future presentation here by the executive director of HSCRC. We've been talking about this population health, this total cost of care, the Maryland model, and let's all get on some level setting about understanding where that is. So that's.
Yeah, I think that's on our list for one of the upcoming meetings already. So thank you, Brad. Any other comments here? I know there's a lot to focus on. We will have the slides available, and there's, you know, we need to sort of delve in deeply. We'll take it upon ourselves from the leadership of the commission to be able to at least put together some aspect of how this needs to be intertwined and coordinated, right, on this approach. I would still emphasize aspects, and I know some of you covered this already from the working groups, and that's looking at, and it's not to say that we're looking at replicating the Indiana report. The Indiana report ultimately was broken down quite simplistically into what? Into each work group or each pillar of theirs saying, what are our goals, right? And I know we started covering this, but what are the goals of the work group, right? What is out there? Ultimately then was a series of what are the recommendations to achieve those goals? And then what are the actions, you know, below the recommendations? You know, now is not the time to begin reading the final report, but even at this early stage, I want to remind you that at the end is what we're trying to achieve through the data that we're getting, and ultimately through the assessment of that data. But it really oversimplified goes to the idea of what are the goals, and the goals can be already discussed. What's the goal of each of the work group? You know, if you look at the Indiana report as an example, when it came to workforce, it was as simple as talking about recruiting and retaining. Right? I mean, that is a goal, right? And how do we ultimately achieve that? There are steps along the way. We also have some updates. Just I want Mina to sort of just give the updates, not quite but Mina, not quite the old business yet, but this dealing with work groups are, where do we stand with the CDC Foundation and support of the work groups?
Oh, great. Well, thank you. And CDC Foundation has been a tremendous partner with Angel to support the Maryland Commission. And as of right now, all of 5 work groups have a work group coordinator. Some of them are provided through the CDC Foundation. And we're hopeful that we'll be able to swing on for a manager chief of staff position as well. That the work group coordinators make sure the work of the work groups is also aligning well together.
Great. So step by step along the way, you know, even without the funding support, we have a lot of in-kind from the state, but we are certainly making progress. And again, the CDC Foundation is there, very interested in what we're doing here, but also very supportive, as is the CDC, right? We were discussing earlier the fact that the CDC finds this idea of states doing exactly what we're doing as a priority right now. Any other questions about the data before we move on to the next segment of our agenda, which is old business? Comments about what you've heard. And again, we'll have more discussions at future commission meetings or even in between. Send emails as you're, you know, looking at the type of data that you're looking at assessing. But I've been reinvigorated just by today's presentation to say that, you know, this is kind of cool where, you know, we are, you know, there are steps ahead, right? And the pathway becomes a little bit more clear, right? So this is kind of cool. Let's move then on to old business, and specifically we have just a brief, old business, I think Mina will take this, which is the, local health department site visits and regional public meetings.
Yes, great, thank you. So we're making great progress. Thank you very much to all the folks of the regional site visits for the commission, as well as the public listening sessions that will be held. There will be 5 public listening sessions and then 5 site visits to local health departments where commission members and work group members will be invited. The first site visit, which will be followed by the first regional public listening session, is actually hosted by the St. Mary's County Health Department. That will be on April 16th, and we'll start at 11 a.m. So for those of you who are commission members or work group members, you'll be invited to participate in that. And of course, the public listening session will be open and be hopefully pulling from all of Southern Maryland. Washington County represents Western Maryland for the site visit. That site visit and public listening session in May to be determined. Montgomery County is one of the Central Maryland sites, and the Montgomery County Department of Health will be hosting on Tuesday, June 4th, that public listening session, as well as a site visit. Howard County Health Department is the other Central Maryland representative, and will be hosting their COPH site visit and public listening session on June 13th. And Talbot County Health Department is representing Eastern Shore, and right now tentatively is looking at July 2nd as the date. So all of this will be shared out once the dates are confirmed, or as they're confirmed for commission members and the work group members, and the public listening sessions will be advertised more broadly once we've got them.
Great, thank you. Any other additions to the old business? Anybody online with old business? Okay, let's move on then to new business at this stage. Again, I just wanted maybe Mina since she was the organizer of our Indiana site visit, to give a little bit of reflections of that.
Sure, and I'll keep it brief because I know we're getting close on time. This is we've got a couple action items as well. So Indiana site visit went really well for those of you who were able to participate. We were really excited to send 9 individuals from Maryland to Indiana to participate in the Indiana Public Health Day, as well as a variety of interviews, essentially, or meetings with so many individuals from their process of public health transformation. And that includes individuals who are represented on Indiana Governor's Commission for Public Health, as well as representatives from Indiana University Fairbanks School of Public Health, who conducted the original assessment in Indiana on their workforce, and recently on their public health system. And it also included a variety of individuals who are now involved in implementing the recommendations that came from the Indiana Commission on Governor's Commission on Public Health. So we learned a lot of lessons. We'll try to summarize some of this in written form for work group members at a later time. But certainly it was a very jam-packed couple days, and I really appreciate everybody who was able to participate.
I do want to thank Mina for organizing this group. Chris was able to join us from the commission. We had others who were able to join us. It was, in my view, also a very fruitful series of meetings. Meeting both with the health department arm, to some extent having the connectivity with the political arm. And one thing that was quite apparent to me, right, was motivation was a little bit different there, right? From the get-go, Indiana was to a large extent reacting to them being rated as number 41 in the country when it came to public health. We have to look at the fact is that we are blessed. We're not number 41 in the country, right? Number 10 or something, right? I mean, whatever, if you believe in these types of ratings. But at the end of the day, that doesn't make our mission less important. Because even if we bring up this idea of looking at the disparities, the issues of equity in our state, we still have the ability to shoot for improvement. And that was my reflection on this. Tosin, any reflections from you? Yeah, just Indiana.
Indiana, I think lessons learned is we need to understand that Maryland is in a unique position. Some of the strengths we have, and then also take a deep dive into some of the areas that we might be unique in. providing, the challenge, right? And then just build on that, right? Again, knowing that our issues will not be the state without states. So again, and from today's presentation, I think that's what we're beginning to just narrow, you know,
Okay, so I just want to so everybody realize that we have been having these meetings with political leadership as well at our state. And we talked quite openly about the contrast with Indiana as well at those meetings. Let's move on. Work group leadership change. And first I'll give in with my editorial comment, which is, guess what, folks? We're going to have turnover here, right? People leave, people come in, et cetera, et cetera. We're not going to be spending time at the commission level every time we have a work group member be in or out. We're going to have various levels of activism within the work groups, right? But certainly what we started with was at least making sure that the commission members were aware of work group leaders and where we need to sort of have work group leadership changes for a variety of reasons. We've always voted here in terms of that, and we'll ask for a motion as Nina describes the changes in leadership.
Thank you. So the two we're asking for is for the commissioners to consider two proposed changes to co-chairs of work groups. One, Bob Stevens, thankfully has been providing service as co-chair alongside Brian, the workforce work group. So Bob will be retiring in a couple months from his role as Garrett County Health Officer. And we're proposing that Sue Doyle, who's the health officer in Carroll County, and has been within the workforce work group through this time, take over that role this month. So that's the first proposed change. The second proposed change, Dr. Branch, the former health officer here in Baltimore County, was serving alongside Dr. Polsky as the co-chair for the funding work group. And unfortunately, he's left the commission and the funding work group and as well as health officer. And so we are proposing that Roger Harrell, the health officer in Dorchester County, who has been on the funding work group and certainly has many years of service both at the local level and at the state health department level, and has a strong familiarity with the funding and public health funding in Maryland, take on the role of co-chair for that funding work group.
Great. Any discussion of this slate of candidates? If not, I'll ask for a motion to, yes.
Are there representatives on any boards that members are staff to MPH?
Yes, so the funding work group is staffed by David Davis from who's the financial officer there, and the workforce work group has Vanessa Lammers, also workforce development director at MPH. We have Stephanie Lewis here who has been working with us and providing support as well. And Delish, of course, Delish Naraman is on our work group of governance and organizational capabilities.
All right, I just want to, it's a resource issue. Right? And we're talking not just about local health departments here. We're talking about the mother house.
Right. No, I think that's a great
I
question,
wouldn't say
Brad.
it's mothers from local health departments, but you're right, it's the state entity.
Or mother less.
Okay, so looking for a motion to approve this slate of changeovers. Anyone? Okay, Chris, move second from Fran. All in favor, say aye.
Aye.
Anyone against? Oh, we check. Anyone we're monitoring on any comments about this? And we have a motion. Any I can't see you, so anyone who's against, please just let us know that you're against. Okay, perfect. So just the commissioners are voting. Okay, so we unanimously approve. Nicole says yes, thumbs up. So let's move ahead with this new slate. We're at almost at the meeting endpoint. This is time for announcements. The only announcement I'll have at this point is April 4th, 2 to 5 p.m. at we hope that our current location remains. I think this has been a convenient location despite the IT issues, and believe that by the end of this commission, we'll get the IT issues settled.
Jack kind of.
But yeah, so Jack is gonna, so Jack from Chris is gonna have to show up at every meeting. So thank you so much for your help, Jack. You'll receive a special commendation. But that's our next meeting. In the meantime, working group chairs, obviously, pursue your further work and your schedules with the working groups. Any other announcements from anyone? Okay, at this point, looking for, what's that? Any announcements or anything from any additions from the internet web world? There being none, I'm looking for a motion to adjourn our meeting here today. Mina, motions, anybody seconds? Fran seconds. All for adjourning?
Aye.
Anyone against? Anyone abstaining? Okay, folks, this has been a good meeting. I'm tired.
You got it.
Yeah.